Good morning, everybody. So lovely to see so many of you here. This morning I'm going to be going through issues with terminology in wound care, and we're just going to explore what that looks like at the moment in current practice. We've got a couple of interactive questions, like Kate says, to try and get your opinions on what's going on at the moment. So yeah, we'll crack on. So it remains an issue that there's a challenge, isn't there, with hard to heal wounds, and that's as evident today as it's ever been. Everyone here today should be aware of Julian Guest's data and the work that he's done on the prevalence of wounds. His work shows that there doesn't appear to be any decrease in the amount of wounds that we're struggling to heal. The community services particularly are seeing these pressures and long term it's inevitable that they're not going to be able to cope with these high amounts of non-healing wounds. And this is even in despite of new technologies and focuses on wound assessment and early intervention that's out there as well. Data shows that hard to heal wounds can be treated in the same way as any other wound, yet it doesn't seem to be the current practice. Jeanette's going to be covering afterwards in more detail in the second half of this the potential solutions that are out there for hard to heal wounds, and focusing on what can be done given the limited amount of resources that's available to yourselves, and also the limited amount of time that there is for clinicians to provide that care. And ultimately, if we want excellence, so for example, we've got the NHS triple aims of the better outcomes, better experience and better use of resources, then we need to look at clinical practice and reduce that variation in practice for both assessment and treatment of hard to heal wounds. This then poses the question for this morning's presentation of whether the different terminology in defining a wound that's not healing could potentially hinder the drive to make those changes in clinical practice that we really want to achieve. So, does the number of words that we use use for a wound that does not heal make the assessment and treatment of wounds more problematic than it should be? And ultimately, does language matter? Well, absolutely it does. And if you read any of the healthcare resources that are associated with chronic wounds conditions, then the focus on language that we use not only to other healthcare professionals but to patients is really evident. The NHS Diabetes resource, Language Matters, talks about language around patient care and how it affects outcomes. And understanding the power of words and how they influence behaviour can help us to ensure the positive healthcare outcomes for our patients. So, does language matter in wound care? Well, for the patient, definitely. And the positive language that we use builds not only confidence in the clinicians, but lowers that anxiety that the patient has and improves that self-care that we want to encourage patients to have. The poor use of language can sometimes stigmatise, it can be hurtful, and it can actually be detrimental to any good clinical outcomes that we're trying to achieve. So what about for you as the clinician? Well, as clinicians, if we're potentially confused about what the different words are that we use for a wound that isn't healing, then that could potentially change the way that the clinician thinks about that wound and how we treat it. So take, for example, the word chronic. Most of us here today would usually assume that having a chronic wound is acceptable to have for a long time. Yet others here today may think completely different. So already you can see that there's that how that becomes confusing for not only the clinicians but for patients as well. The term chronic can be viewed differently again by the patient. So they could be distressed by the word chronic wound because they may have potentially heard the term chronic conditions and what that looks like for them long term. Now I want us to have a think about how does that potentially change the way that we treat a wound? Are we as reactive to changing treatments when the wound isn't responding when it's chronic? Are we reassessing those wounds often enough? Does managing a wound rather than treating it become the norm as well? And does this attach a stigma to the patient with a wound? That stigma, no matter how big or small it is, can influence the perceptions of healthcare professionals. And what does that impact have on the patient? Ultimately, what we don't want is for patients to become disengaged with their care because a wound isn't healing. For us to promote self-care and shared care, the choice of words or terminology really does matter. We need to be clear in our own minds what non-healing wounds are and how to treat them. So remember, the choice of words that we use has enormous power, which can have both positive and negative effect, but also that some words and descriptions are potentially problematic for both clinicians and practice and the patients. And it seems appropriate now that we review the use of common terminology in wound care, and particularly wounds that struggle to heal. The reason that we have terminology in the first place in healthcare is so that we can communicate a common and consistent language between us all. And it's specific so that, that we should all be able to, at some point, if we're treating the same patient, we should all be able to treat that patient in the same way with the same terminology. And if it's used appropriately, it should eliminate any misunderstanding or vagueness. However, when we look at terminology in wound care to describe wounds that aren't healing, we've created the very thing that we're trying to eliminate, and that's that misunderstanding and vagueness. And so we look to research to help us. Cho et al. In 2017 found that only a few studies on chronic wounds had been included in systematic reviews due to what they called the great disparity in the terminology and definitions of a chronic wound. We won't be covering definitions today, but when you think around discussions on wound duration, for example, it's in relation to being deemed as hard to heal. There's documented evidence with different criteria to help us to make clinical judgments. So, should a wound be judged hard to heal at 3 months, or when it's reducing in size by 20 to 40% after 2 to 4 weeks, or when there's no complete healing after 6 weeks? With this many variables to consider, there's no doubt that it's confusing for clinicians. You'll see on the screen now that there's a variety of words that have been used to describe a wound that's not healing. We've got words like chronic, stuck, hard to heal, non-healing. No wonder we're all so confused with so many words that we're using. The problem is we're using different wounds, which ultimately describe the same thing. But each term potentially has its own definition, or a clinician may interpret it in their own way. And if we can choose a term in which accurately reflects a hard-to-heal wound, then we might be in a better place to start to reduce some of that variation in clinical practice. Now, I'm not suggesting that we simply change the term that we use right here, right now, or that changing that term will impact on hard-to-heal wounds on its own. And of course, there's always wounds that will not go on to heal. So, for example, patients that are, maybe we're looking at quality of life, or we're looking at patient comfort. But rigorous wound assessment and effective management of comorbidities and appropriate and timely treatment interventions give us the opportunity to change the future outcomes of the ever-increasing wound population. And above all, we need to understand, address and manage the challenge of hard-to-heal wounds. So, in turn, this will lead to better clinical outcomes, improve patient quality of life and reduce overall healthcare costs. So, you've all got your Slido apps to hand. So, what I'm going to do is we're going to go through a couple of the questions, and then afterwards I've got the survey results that we've done. So, I'll share you the top line results taken from the clinical focus survey that we did. We asked questions about terminology in wound care and whether the respondents thought excuse me, that having too much terminology for hard to heal wound would impact on assessment and treatment of wounds. So, first question, there's a lot of different terminology used to describe wounds that aren't healing. Does that make assessment difficult or challenging to understand? Yep, I think. Yeah, so we invited clinicians to participate in this survey with a variety of backgrounds. So we asked tissue viability nurses, acute nurses, podiatrists and practice nurses. And when we had the answer to this particular question, 87 out of 149 people said that it did impact and they found that assessment was difficult and challenging. So your results today reflect on that, that initial survey as well. Just to go into the survey details a little bit more. So 50 people said that it didn't impact on assessment, and 12 said that they didn't know whether it did or not. A large proportion of the 50 people who said that there was no impact were either tissue viability nurses or considered themselves in an area of being a wound care specialist. The 87 people who said yes were predominantly community nurses. So over half the respondents felt that having different terminology made assessment more difficult. So then we asked what terminology the clinicians would prefer to use for a wound that is not healing according to plan. So if you want to go back to your Slidos now, the next one's up on there. So what terminology would you prefer to use for a wound that isn't healing according to plan? I think that's everybody, isn't it? Perfect. So you can see that even that in itself, there's a lot of discrepancy and variation between what we're using just in this room. So based on the survey that we did, there we go. You can see that over a third of respondents said that they preferred the term non-healing, followed by hard to heal and then chronic. In the other category were terms such as complex, stuck and static. So I think it's very reflective of what's thought about in this room as well today. And it might be an opportune time to try and understand what drives this choice in terminology and how consistency with terms that we use in practice can drive a change to improve those outcomes. And then just one more for you. So what was the reason for your choice in terminology? So what was the reason that you picked the term that you did on the last question? Okay. So not quite as clear cut as it was on the survey that we did, but we asked the clinicians for them to state the reason, and the largest response that we got at that moment was that it was easy to understand for all healthcare professionals. Remember at the beginning we said that the primary reason for medical terminology is that all healthcare professionals have a common and consistent language. Well, using consistent terminology should, if used appropriately, eliminate that misunderstanding and vagueness, and that's ultimately what we want to achieve moving forward. Thank you very much.
Thanks, Lauren. Definitely some food for thought. In terms of implications for practice, it's really important that we think more widely about that. If we are all using different terminology with our patients, how can they know what we're trying to say to them? How can they engage in the right way about what we want them to do? And I think it's really, really important that we start having these debates. For me, the word chronic almost appears that it's something that I'm going to have for a long time. But yet when I speak to patients, the overwhelming thing that patients say to me is, when is it going to heal? When is it going to get better? And there is that hope, isn't there? Everybody has this huge hope it's that indomitable human thing to hope. We've all been through 2 years of awfulness, really, and it's really brilliant to be here in front of you all today, actually face to face. I've sometimes felt that my life has been diminished into a little box at work, in a senior nursing role where I've just kind of operate in this Teams world. So it's brilliant to be back and seeing people face to face again. But I think it's really important that we think about the implications for practice, because patients do get stuck in the middle. And I think it's our time now to have that call to action. I'm getting a bit of feedback from this, so I'm just going to pop it down. So the call to action itself is for everybody. It's our responsibility collectively, irrespective of what your role in the system is. So you may be, a chief nurse like myself. You might be a nurse on the shop floor. You may be a tissue viability writing practice guidelines for people. Or you may be working, in environments where you see very few wound patients, but you've all come today for a different reason. And that might be from a revalidation perspective. It may be that you've got a real passion and a burn in your belly around wound care. But from Julian's data, what we know is the number of wounds is growing. If anybody watched the news yesterday, we know that we had more registrants leave the register last year than we had join in the UK. We've got a huge staffing crisis. So how are we going to do more with less? Not just necessarily from a financial perspective, but from a staffing perspective. And I think we have to go out and try and not manage wounds, but to heal them. That has to be our goal, and we have to implement practice much sooner to be able to do that. There's lots of reasons why we don't act. I would hate to think, and perhaps I'm naive in this, but nobody gets out of bed in the morning and thinks, I'm going to go to do work today and do a really bad job. Does anybody have that thought as they get out of bed in the morning? It's definitely... I often have a really bad day because things happen and it doesn't go quite to plan. But I didn't get out of bed thinking, I'm going to do a bad job today. And all of these things affect us. Our focus can lapse because we bring our whole selves to work. There's often things going on in the background. The resources that you have available can sometimes be restricted. The time that you have and the time that you would like to spend is often a huge disconnect, isn't there? Because we're rushing, especially if you're working in community, you might be rushing from patient to patient. I manage the district nursing services in our organisation, and I would love to say that it was like back in the day where the district nursing services might have had sort of 8 to 10 visits, but a lot of our teams now are running on 18, 20 visits, that are just rushing from one to the next patient. And we need to make it easy for those staff to do the right thing. We need to put processes in place to reduce cost and improve efficiencies. And that's really the only way that we can manage things. What do patients want? I said at the beginning, a lot of patients will say, when is it going to get better? They want that definitive. And what do we tend to say to them? In my day, many years ago, I might have been thinking, well, when the moon and stars align, it's the hardest question that a patient will ever ask you. And then we started to get some definitive research about percentage reduction and that being a good prognostic indicator in wound care. So if we can have standardised measurements, we can try and give that trajectory to a patient. Now, I'm not saying that you wouldn't want to give your get out of jail card in that, in as much as that's assuming that your health remains well, and other things. You don't get a wound infection. There are lots of things that would impact on that. However, if all things go to plan, we expect that this will heal within this amount of time. We've got really good data for venous leg ulcers. the problem that we have with venous leg ulcers is getting people into compression. And, you know, the Legs Matter campaign has a brilliant survey at the moment, and I would encourage you all to answer that survey, because the more information we can get in these domains means that we have much better data to be talking to different delegates about. But ultimately, patients tend to focus on the things that affect their life. And we know that wounds affect people's lives. They affect them from a functional perspective. They affect their daily living. They affect their ability to work. And pain affects so many different assets and facets of life. So making the case for negative pressure then, these wounds perhaps are not ones that you might think are the best for negative pressure. However, this patient is a young woman who's in her 50s, who's had a laparotomy. The wounds were healing really well. She then had her COVID jab. So I don't know whether that had anything to do with it, but the COVID jab broke down the actual wounds. There was probably a bit of hematoma in there anyway. Can't necessarily always see depth, but these wounds are quite deep, but very small. A lot of pain, but essentially, perhaps in your practice, you may have chosen to pack that and bring that patient back. All this patient wanted to do was go back to work, be functional, be able to go to work and, you know, get on with their life. So at day one, this image here, which is possibly about 10 days post-op, and then at day 4 from starting a single-use negative pressure device, you can see that that single-use negative pressure device has been used on 2 of the laparotomy sites, and it has transformed the way that the wound looks. The wounds are at, that bottom wound there is the one that you can see in the first picture. And you can see that it's just taken away that inflammation. It's taken away some of the things that would potentially lead to more chronicity and just turn that trajectory around for that patient. The other thing about younger patients with single-use negative pressure, it's really easy to teach them how to apply it, especially if it's on an abdomen. It's really easy to teach somebody to apply that themselves and use it in a way that means that that reduces the amount of times that they need to come back and see you. And I think the other thing that's been fantastic about the pandemic, definitely in England, is that the amount of telemedicine that has come about as a result of it. So for these patients, you know, a bit like you guys would, I always love a bit of Slido. You see the kind of sliders going up and down, and the first person to vote kind of can influence other people, and then you see the percentages going up and down. But that is real time. And we now, with telemedicine, can give people the ability to ring into a clinic, to book an appointment, to see somebody remotely rather than being able to travel. We've done an awful lot of work in Northumbria in relation to that. And the important thing for patients isn't always being seen face-to-face. I think what we've found is that patients want choice. They want to be able to decide how they're seen. So if they want to be seen face-to-face, they'd like a face-to-face appointment. But if they can opt for face-to-face telephone or video consultation, then that is fine. It's about giving our patients choice. Lauren talked about the publications that Julian Guest has done, but there have been an awful lot of publications on negative pressure wound therapy. There are medtech guidance out there from NICE, and it's formed an awful lot of my publications over the years in terms of using negative pressure and its effect on patients and quality of life, using negative pressure in conjunction with compression bandaging. And those publications have been very much case study, case cohort, but there are all different kinds of evidence within the portfolio around negative pressure. And there is continued work within the surgical wound fraternity. We are currently recruiting patients into a surgical wounds healing by secondary intention, where we're randomising people to negative pressure or standard dressings to see, you know, which is better. And that's a large trial. I think they're currently at about 500 participants that we've recruited into that. Not just us as one site, of course. You know, that would be outstanding from a recruitment perspective, but that's from multiple sites across England. We know that economics play a huge part in wound care. 67% of our expenditure is spent on 30% of wounds. We need to somehow turn that on its head. The biggest cost associated with wound care is us. It's our salaries. It's the clinics that we have. I don't know about Scotland, but definitely in England we are facing recruitment crisis. We are struggling to recruit. We have more staff vacancies. We still have COVID having not really gone away in healthcare. We still have a lot of staff sickness as a result of COVID because we can't have staff coming to work with the potential to infect somebody in this litigious society where somebody's going to say the nurse gave my relative COVID, and ultimately that relates to a claim. But all of this has a huge burden on you as staff. And the frequency of dressing changes and the cost of dressings is that small percentage in terms of the overall cost of wound care. We need to think about how we can improve outcomes, but overwhelmingly as well, improve patient satisfaction. And a lot of patients, you know, historically, you would be saying to patients, well, you could look after this yourself. And they would be like, oh, you know, I paid my national insurance. I expect you to come. You know, they didn't used to say that, but it's like, I expect you to come. I've seen some patients that would almost take their leg off and give it to you, and, you know, give me it back when it's better, as opposed to entering into a partnership. And I think it is a partnership, and it's about selling an outcome to a patient. And that selling an outcome to a patient is sometimes about engaging in what they want, looking at their activation for what they want to achieve, and addressing some of the lifestyle factors that might be impacting on them achieving a healing outcome, and being honest with them. It's no use if you're on two different paths. That's when things tend to occur. In my current role, I would say the worst bit of it is complaints. Incidents, complaints, and claims. We spend an inordinate amount of time writing complaint letters that are screeds and screeds long. And if I'm honest, a lot of that comes down to communication. It's usually a breakdown in communication. Somewhere is the golden thread. And we need to not only be able to say and express that to patients, but we need to document it, because we often do it, but writing it down is the problem. These are some of the things that patients have said to me over the years. You know, everybody does something different. And I don't know why. I've been into some patients' homes in the past where I've opened the cupboards in the kitchen when they've gone, oh, the dressings are in there, nurse. And they've almost had more than the chemist. You know, they've got all sorts of, you know, before you use your prescription pad, there's all of the things that people have used on my wound. And staff tend, it's easier to blame something that's inanimate than look inwardly and think, perhaps I didn't assess this right, perhaps that diagnosis isn't right, perhaps I've got suboptimal compression on this, perhaps we need to think about the offloading and the patient behaviours around that. And, you know, the biggest thing you'll do in a pressure ulcer is get the pressure off and improve the patient's nutrition and mobility. And we've got a responsibility to get people moving more if we can. And that's not always possible. But I think it's really important that we think about the impact that we have. This slide, I suppose, for me, is that we don't always do what is right. We don't always make the most healthy choices. How many of you, you know, always go to the dentist? Well, going to the dentist really in the pandemic, it's been difficult, hasn't it? You've had your checkups. You know, you've been to your GP to say, feeling really good today. What can I do to make me feel better? today. We don't have a health service, do we? We have an ill health service. We only go to these people when there's something wrong. But we all have that responsibility. You all walked 12,000 steps yesterday. You all had no sugary pastries when you came in the door that were available for breakfast this morning. And, you know, perhaps most of Glasgow that are Rangers fans had a few drinks last night on a school night. You know, because football is very much the beating heart of this city, isn't it? Having kind of taught here for a number of years. We don't always keep up our hydration or nutrition. So patients are no different to us. We have to think about what we would want if we were them. And often healthcare professionals will choose very different things for themselves. If we look at realistic medicine towards palliative care, lots of clinicians would choose very different things than they would offer their patients. So lots of them wouldn't be ventilated, lots of them wouldn't choose to go in hospital, lots of them would choose not to be fed. However, we offer patients those choices without really explaining the rationale for those choices. And it's probably because we're driven by the thought of needing to do something, as opposed to sometimes doing nothing is the right thing to do, or being much more aggressive to try and force that outcome of healing as soon as we can. So I think we have an opportunity through crisis. COVID is a brilliant example of that. It was a huge crisis, the biggest crisis that I've ever managed through my health career. But out of that comes opportunity, and we have to think about building on them and simplifying care and making it easy for people to do the right thing and improve continuity. And pathways are one way of doing that, aren't they? You have choices, and patients have choices, but it's really important that as clinicians out there, you know, yes, go and see all of the stands down there, but there's a plethora of information. And, you know, sometimes it's easy to be confused. And tissue viability staff, and, you know, I was one for a number of years. I led services. We try and do that. We try and reduce the choices that you have with things like formularies. But often some of the more interactive products are perhaps for specialist use only. And I have a real passion about that. So I want you now to have your say with Slido. So do you have pathways in your area to support community nurses to treat hard to heal wounds? Wow. Do you find those pathways easy to follow? Are they paper-based pathways? Yet you've got electronic systems. Are they embedded? Do they help you to do the right thing? How many of you are using systems such as System 1, EMIS Web? Yeah, just a show of hands. System 1, EMIS Web. Not easy to embed pathways in those things. So we tend to have a push towards pushing people into using electronic records. However, no way of making that pathway embedded within the system, or very difficult. So it's interesting that, you know, at first 80%, and then as more people have kind of logged on, we've now got only 40-odd% of people easy access to pathways to make the right choices. I think it's really important to try and simplify decisions. So this is one of our Northumbria Trust pathways, and it's about negative pressure. So it's asking people really simple questions. When we first did this, it was a paper-based form, but we have tried to embed it within the clinical record for our staff to make it much easier for them to flick between something. And it's just taken them down a series of questions. So has your patient got one of these things? A dehisced surgical incision, an incision that's inflamed or leaking, and we also have a pathway for perioperative care as well for our high-risk incisions. But have they got a venous leg ulcer or a mixed etiology ulcer? Are you visiting multiple times a week? Because where you are visiting multiple times a week, you can free your time to care with negative pressure, assuming that you pick the right patient. So the next questions are around the patient. Do you feel the patient would cope with this therapy? Can they carry this therapy? Obviously, with smaller devices, that is less of an issue, but with the larger devices and the large canisters, you need to think about whether there's a falls risk associated with giving somebody a large device, you know, especially if it's on an amputation site and they're having to go to the toilet and navigate through the home in a wheelchair and the risks associated with that. Would you be able to get a seal? Is it in an area where you would get a good seal? Because it can often cause stress to patients if you wouldn't get a good seal. But you can see here it's trying to take people through a logical flow of questions and make a sensible decision. And it's definitely evaluated really well in my area. We've got to sometimes also think about our patients from a perspective of what goes wrong. So this is a patient of ours who had single-use negative pressure therapy put on post-operatively. So this patient was a large lady, 54, who'd had an elective gynae-op for cancer. She had PICO single-use negative pressure put on post-op as part of the high-risk pathway. It was taken off at day 3. And instead of it being replaced, it was left off. We all know that the lower end of these wounds is the most difficult place because in the pannus, there's a huge amount of pressure there. So you've got sutures. She had a large hematoma, and there's probably a 50-50 chance here that this wound would have broken down even if they'd continued with that sort of high-risk surgical pathway. She ended up with this is the wound once it was kind of opened, but this is kind of a case that has become a claim within the organisation. But at first it was just open at the bottom end, and what staff were doing was packing 8 hydrofibre dressings into that small hole. The cavity inside was huge. It was a bit like trying to wallpaper your stairs through the letterbox. They were using a probe to try and determine the depth of that rather than using a gloved finger. Now, some people can be horrified about using a gloved finger, but at least with a gloved finger you can feel. You can feel other anatomy and structures, you can feel sutures, you can feel left dressing material. But that is what happened in this lady. She had retained dressing material and ended up going back and having this wound opened again, and then had negative pressure applied to that open wound, which is the one that you can see here. But that delayed healing for that lady. And there is an argument and an ongoing case that is being debated around whether that affected her ability to have chemotherapy and whether that affected her long-term survival prognosis. So sometimes we have to really look back. We were brilliant in the records at saying what we'd stuffed in there. Brilliant. Not one nurse perhaps had said not what they'd put in, but not one nurse had said what they'd pulled out before they put stuff back in. And it's really difficult with some of the dressing materials. The hydrofibre becomes a very amorphous kind of gloopy mass, doesn't it? The one that we use is stitched. So there is an argument that they could have tried, but again, time probably had an impact. It didn't help that she was managed by the nurses on a ward, she was managed by a district nursing team, and getting her back in to see a surgeon was traumatic. And at no one point in her 4-month history with that wound was she referred to the tissue viability team, which is also probably a failing from what we did. So, you know, there are consequences for patients. This lady ended up with 3 operations, delayed healing, delayed chemo, and huge increased costs. Whereas if we did things differently, if the surgeon had opened the 2 things from the beginning, you know, we could argue that at that point we were kind of set up. But if they'd been referred to tissue viability, if somebody had put a gloved finger in there and been able to sort of feel what was going on, if they had not packed in the first place and used a cleanse and drain scenario, which would have been my preference, especially at a lower end, using something like a wound drainage bag, as opposed to trying to pack something where you don't know what's going on inside. So it is time for change, and I think it's really important that we think about, coming off the back of the pandemic, how do we keep some of the momentum? How do we make sure that those patients that were willing to self-care continue to self-care and do so in a supported way? I'm not talking about self-care where we're just posting dressings, you know, through doors, because we saw things like that happen in our areas where patients that were vulnerable and elderly were really frightened that that nurse was a vector. And we've seen huge safeguarding increases as a result of that. So I'm not talking about just posting people dressings. We need to be encouraging their supported self-care. This case study is another that perhaps you wouldn't historically put negative pressure wound therapy on. So this is day 1, which was 3 days post-op in a young lady. Sometimes in an organisation, when you kind of get to a point where you've got all of the execs and various things on WhatsApp groups, you get the most random pictures sent to you. So this is a colleague's daughter, and I'm getting these random pictures sent on WhatsApp. Jeanette, what do you think? She's had an appendectomy. What do you think of this wound? Do you think it's going to be all right? She's going back to urgent care to see whether it's going to be all right. And I was like, the first picture I got, well, it's bruised, you know, but that umbilical wound may well break down. And then you can see here, the second day, we've started to see some signs of it breaking down. And then, actually, this is not day 31 here. It's day 10 and day 11, so I don't know what's happened to the slides there, but it's definitely not. So, you know, she'd been back at day 8 to ambulatory care. They'd given her some antibiotics. They'd told her to change the dressings herself. They'd just given her a dry dressing, and her mum then WhatsApped me again. She just wants to go back to work. She doesn't get sick pay. She's got an awful lot of pain. She's really worried. What can we do differently? So I brought her into a clinic. We put negative pressure on, and that was at sort of this kind of sort of between day 3 and 5, I would say. We put the negative pressure wound therapy on. I spent a lot of time with her saying, these are your options. You know, you can have this, you can have that, you can have this therapy, you can carry it around with you. This is how you put it on. This is the spare dressing. So she then changed that at day 4, the single-use negative pressure. And then this was when that was taken off at day 7. And she kind of went back to work with just a simple dressing on. Would it have broken down? We will never know. Did it heal quickly? Yes, it did. And I know this kind of 31 and 35, but this was kind of concluded within 2 weeks of her surgery. Inertia is really difficult in healthcare. And when we do any change management, we need to think about where we're going, you know, and what our transformative ideas are, and how we integrate them, and how we move people through that. And it is scary sometimes, and it's about collecting data. It's about being the best that you can be. I started this presentation by saying nobody goes to work to do a bad job. You will have a passion for something, and you will be able to affect change in something. And one of the best speakers I ever heard was somebody called Steve Head, and he talks about glimmers of brilliance. Look for your glimmers of brilliance in your workforce and nurture them. Water them, help them to grow, help them to make these changes in practice. Do it through a PDSA cycle, collect some data, know where we were to start with, and then move through the system. He also talks about this 149 effect. And, you know, for those of you that haven't heard him, what he talks about in that is that we shouldn't be afraid to fail. And in healthcare, it's often really difficult to say, oh, we tried that and it didn't work. Why did it not work? What could we do differently to make that work? Or is it fundamentally flawed, the pathway that you've put in? Or is it the fact that it's not embedded into the clinical record and it's not easy for people to access it? Is it in negative pressure wound therapy that the people at the grassroots, at the surface level, cannot access it? And I think we have to ask ourselves some clear questions about that. The biggest innovations come through failure, not success. I'm sure Einstein, Newton, all of the big kind of breakthroughs, Elon Musk in terms of Tesla and everything that he's done and the fact that he's a billionaire today, didn't always come through his successes. It came through his dogged grit and determination to make it and to make it work and to learn from those mistakes and move on from them. And I think, that's why I included those slides about that lady. It's really important that we hold our hands up and say, we got it wrong, we failed you, but also that we can do better. And that doing better is through communication. And that doing better is challenging us to ask questions about what we're doing to try and improve. And in this scenario here on this run chart, I don't know about yourself now, but the NHS in England loves a run chart. We love a run chart. This one was about reducing pressure ulcers in our organisation. But equally, you might want to look at reducing the length of time a wound's open. You might want to look at how quickly you heal a wound. But everything can be plotted somewhere. And often when you're talking to the peers and those people that are managing the budgets, procurement, CCGs in England, the health boards in Scotland and Wales, it may be that this kind of data is what you need to collect. We can track wound outcomes. It's important that we're all measuring wounds. It's the one prognostic indicator. It's important that you're all having a conversation about how you do that in your organisation, whether you're doing north to south, east to west, using a clock face, trying to make it reproducible, whether you're using sexy cameras these days that will measure the wound for you. The National Wound Care Strategy is looking at apps and things that will have all of those things, so you can have these things at the point of care. You can use them with the patient. You can measure that trajectory. Not many nurses came into nursing to be a photographer, to be a mathematician and kind of work out percentage volume reduction and regression. And of course, when we do measure a wound, we make it into this cube, don't we? Unless you use something like an ellipse formula. But those things are coming, and they hopefully will help us to heal wounds as quickly as possible. But we do need to simplify things. We need to use data and we need to share. But most of all, we need to celebrate. Like I said about Steve Head, look out for your gobs. Look out for those glimmers of brilliance in your workforce and grow and nurture them and try and sort of make them, give them and empower them to be the best that they can be. I want you to have your say now again. Do you think all wounds should be referred to a tissue viability service, or should some be treated by nursing teams? Our current service in Northumbria has any wound that's failed to heal at 4 weeks should be referred to tissue viability. I would argue that if all of those patients came to tissue viability via a referral route, the tissue viability nurses would be on their knees. So it really is about us empowering our community nurses, those nurses working in care homes, those nurses working across the third sector, nurses working in acute settings, to do the right thing, to be the right thing, to have the knowledge and education. Not everybody will have a passion for wound care, but everybody has a passion to do the right thing for our patients. And that's my call to action, that we need to be doing the right thing for patients. We need to act first and beg forgiveness. So if it's on the formulary for a specific thing, but you know that it will help that patient, act, collect some data and beg forgiveness. It's sometimes quite scary, but ultimately that's what we need to be doing. We need to be taking calculated risks for our patients because we know that it's the right thing to do. We've talked about the reasons why, but ultimately, how good do you feel when you heal somebody's wound? How good does that make you feel when you make that difference to a patient? I don't think I see many nurses come skipping out of somebody when they've got a wound infection and think, oh, I did a good job today. So we've got to get our salve to our soul somewhere, and healing patients quickly, empowering patients to make the right decisions and the right choices. And also, some of those will be difficult choices for our patients. You know, sometimes it will be about managing the symptoms of a wound. I'm not standing up in front of you today saying that we will heal all of these wounds. That would be lovely, wouldn't it? You know, I could probably retire tomorrow if I came up with that little, invention. However, we need to heal wounds, not manage them. And we need to do that by diagnosis and getting the diagnosis right, and then using augmented treatments in the best way at the right time for the right patient to affect the right outcome. And we need to be reducing the hangover of wounds that are out there. Thank you.
Thank you, Jeanette. Is there any questions for Jeanette or Lauren? Sarah.
I was going to say that to you, Mike.
Thank you, Jeanette. Great presentation, thank you. I don't mean to put a damper on things, but we talked quite a lot yesterday about clinical leadership, and we know the messages, we want to make that change, but we're dealing with a workforce that are generalists, juggling lots of balls, and who lack support at root, at sort of, you know, the coalface, as it were, when they're trying to make these day-to-day decisions to move wounds on to healing. You know, what's your experience? How do you achieve that in your area? Because we have to rely upon good clinical leaders, say in district nursing teams, to be able to support those staff, and it doesn't always happen. You know, we're desperately trying to make a change as tissue viability nurses, but we can't do it all. So have you got any ideas of how that can be achieved?
So I think it's a really good point, Sarah. I think in terms of our biggest challenge is the tiredness of the workforce that's out there, and giving people time. It's really hard, isn't it, to square the circle of giving people time to train and reflect and make changes in practice when they're on this day-to-day hamster wheel. I think we have to think about doing things differently, and perhaps that is about, you know, reinvigorating things like champion programs and things, and trying to make planned and unplanned care from a district nursing point of view separate, so that planned care doesn't get bumped for the unplanned. But it's really about creating headroom in the system. And what we've tried to do is think about how can we inspire people? So how can we kind of water those glimmers of brilliance, those people with a fire in their belly that come to the training courses and want to change the world and then they join the workforce? How can we continue that, and how can we enable them by getting the systems and processes in place that make it very easy for them to do the right thing? It's not easy, but you know, I'm passionate about trying to affect change for patients, and I think that's what we've got to do. We've got to keep that passion burning in people, because people genuinely want to do a good job.
Any more questions?
Great presentation. I'm from Southern Ireland, so I've come here and you're fantastic. But I'm a community nurse for 10 years and I'm finished my A&P programme. And it does, for me, it makes sense that if the community nurse is invested in, has the capacity to prescribe, like we all know, and I don't work for Smith Nephew, but we all know it's a great product. I don't understand why the investment isn't that the nurse can prescribe, the patient satisfaction would improve. And how on earth are we going to look after 18 clients in a day, like you said, and be holistic? Like, I find that the more the word holistic is bantered out, you see less and less and less. Like, it's just terrible to think that the word holistic is bantered, and you can do way more than just 2 or 3 in a day if the holistic is attached to your name. Like, I have no intention as an A&P to only see 3 people. Do you know what I'm trying to say? Like, I think it's just devastating. Devastating.
Definitely. One of the things I'm most passionate about in our organisation since I've kind of moved through the ranks is, why is it that as nurses in our job plans, the further you go in your career, the further you get away from patients? I'm really, really passionate about that. And I think we need to address that. We need to be putting some of that senior leadership back at the front line. And I think it's an excellent point. We've got an opportunity in England because the district nurse course now is M level. They're all coming out with clinical skills and prescribing. But that also is a challenge because we've got other roles in our organisation where those roles are, banded as a 7 and 8A. And the current district nurse and team lead role in our organisation is banded as a 6. So I've just written a paper to board to say we need to do something here, otherwise district nursing roles will be that transitionary role and they'll move further and further away from patients at the coal face, which is where we need them. But actually we also need to put additional roles into that to make sure that they're not just triaging from an office and they're actually out there in practice. So we've got huge challenges. I'm not coming to say that, I'm, this glass half full person who's always got all of the answers, but I think we need to be having the difficult conversations.